Okay, I think since it's 12:15, we'll go ahead and get ourselves started. So welcome everybody for coming to our next South Zone Echo series session on the inherited patient on opioids. I know this is going to have a good topic for everybody to participate in. Many of us have had these types of patients come to us. So just a couple of things that we want to go through. We want to start with our land acknowledgement. We'd like to recognize that we are webcasting from and to many different parts of Alberta today. The province of Alberta is located on Treaty 6, 7, 8 territories and is also the home of the Métis Nation of Alberta and the 8 Métis settlements of Métis homeland. This land is traditionally meeting ground, and home for many Indigenous people. We'd like to ask you to take a moment to reflect on what truth and reconciliation means to you and consider some of these calls to action from the Truth and Reconciliation Commission of Canada. Thank you. Next, I'd like to just introduce myself. Some of you who are from the South Zone already know who I am. My name is Abby Scrovey. I am the optimization director within the Palliser PCN here. I have no conflicts of interest other than the Palliser PCN does employ me and provides me compensation for today. Great. Next slide. Just a reminder for any of those of you who are new to joining our group, we do have a live recording, and I just want to kind of go through a couple of things so you're aware. The didactic session is being recorded, so please note that when you're participating, you understand that you consent to the sessions being made available through the ACFP webinar registrants. Also, these recordings are used and stored in a library for some continuing professional development opportunities in the future as well, okay? So just so you're aware there. Great. We will stop the presentation or the recording when we get to the case presentation and the discussion for suggestions with the case as well. So just before we get started into our didactic pearls that Dr. Montgomery is going to share, I just want to ask that you hold your questions till the very end of the presentation, because I know it's going to be a pretty quick presentation from Dr. Montgomery here. So if you can do that would be great, and then we can all participate afterwards. So does anybody have any questions or concerns before we get started? Okay. Excellent. Okay, so I'd like to introduce our presenter. Many of you probably already know Dr. Montgomery. She's a family physician with additional training in chronic pain. She has a focused practice in chronic pain as a part of an interprofessional team in Calgary and works with Alberta Health Services in system integration role. One of her responsibility in this role is helping primary care networks develop pain resources for their patients using a cognitive behavioral therapy-based rehabilitation model. She is involved in teaching residents, providing continuing professional opportunities related to chronic pain. Clearly, she likes teaching and she has research interests in ranging from opioids, fibromyalgia, cognitive behavioral therapy, and communication skills. So I know I am so looking forward to hearing from you, Lori.
Well, thank you. I am going to try to tell you everything I know about the inherited patient on opioids in 15 minutes. Maybe not. I think the next slide is our conflict of interest. Yeah. So I do have a grant from the Hotchkiss Brain Institute, which is part of the University of Calgary. And Alberta Innovates for a clinical trial that is related to a medication for opioid withdrawal, which I'm not going to talk about today. And also a CIHR grant to study implementation of the ECHO model. So I have conflicts all over the place, but just so you know what they are. Nothing related to industry, no connections with industry. So the learning objectives look quite ambitious. We're going to describe an approach to assessing and managing a new patient who's on long-term opioids and come up with a personalized management plan, which I promise is not as complicated as it sounds. And we probably can get through the high points in a few minutes and try and leave some time for questions. Next slide. So starting with a case, which probably will set, and especially from the looks of the case descriptions that you all submitted when you registered, seems like possibly a fairly common one. So Robin, who's 44, moved to Medicine Hat recently from Edmonton. Long history of low back pain and chronic opioid therapy. So probably alarm bells are going off about this, all kinds of things about this medication list, which we'll maybe have a chance to talk a little bit about. Next slide. So everybody's first concern when they're inheriting a patient who's on opioids is, what's the college going to think? I promise you the college wants you to take this patient on. The last thing the college wants is for this patient to be orphaned without a prescriber and end up wandering around looking for opioids from somewhere else to continue, because given the issue that we have right now of unsafe supply, it is almost guaranteed that what they find will not be the opioid that they think it is, and it's extremely dangerous. So there are multiple documents and multiple ways that the college has tried to make it clear that they absolutely do want this patient to be taken care of and the opioids to be prescribed safely. There is a standard of practice that you need to adhere to if you're taking on a patient who's on opioids, which I will talk a little bit about, but encourage you to have a look at this. And it's a couple of pages long, it's very manageable, and probably nothing on there is going to take you too much by surprise. Next. So pretty basic. The college would like you to take a history, which hopefully you're doing anyway. Do some physical exam and come up with a pain diagnosis. So that doesn't mean you need to justify opioid therapy for this person based on the pain diagnosis. Chances are, and mechanical low back pain, which is the diagnosis that this patient has in the case, you wouldn't probably initiate opioid therapy for that. It's not that you need to have a pain diagnosis that justifies opioid therapy. It's just that you need to have some idea of what it is that you're treating. So you need to make a pain diagnosis, and you need to document that you've had some conversation about the alternatives, opioid therapy, and what the good, the bad, and the ugly are in terms of risks and benefits of opioid therapy. So when you're meeting the patient, just having a talk about what they've tried, what things might be options that they haven't tried, and make sure that they understand the potential downsides of opioid therapy. So on the next slide, there is an example of how you might document that you've had that conversation about the risks and benefits of opioid therapy, which is our opioid agreement. So some people have a tendency to sort of treat the opioid agreement as if it's a magical lasso that's going to keep the patient from doing things you don't like. And they say the opioid agreement doesn't work because they still do things I don't like. That's not what this is. The opioid agreement is just a way for you to document that you've had this conversation. If you want to document the conversation in a different way, that's totally okay too. But this is sort of a way of making sure that your conversation with the patient is fairly consistent each time you see a different patient on opioids, because it sort of guides you through all the things that you want to have as part of that typical conversation. So the typical side effects, the long-term adverse effects, and what your expectations are around opioid therapy, that they're only going to go to one prescriber, they're going to, all of those kinds of typical things that are just really the conversation that you want to have to set some common understanding, I guess. Next slide. So the standard of practice from the college doesn't say, you can't prescribe more than X milligrams of opioids. What they do is they endorse a guideline and say, so the way that it's phrased is that you should, in most cases, adhere to generally accepted opioid practice guidelines. And then it says if you're not, meaning if, for some reason you're feeling like currently our guidelines that we're using say that in most cases you probably shouldn't go beyond 50 milligrams morphine equivalent daily dose, you really should be very careful about going beyond 90 milligrams. And so the standard of practice says justify your prescription, document the justification if you're using something outside of that dose range. Remember that this guideline exists if you're initiating opioids, and they're just saying don't go above this level. So your justification for going beyond this level for Robin, for example, if you're taking on Robin's prescribing, it will be beyond 90 milligrams morphine equivalent dose. If you go to the next slide, your justification really is just the patient has been established on this dose for X number of years. That's all it needs to say. You don't need to you don't need to have any more complicated rationale than that. The college does not expect you to taper a patient who's not ready to taper, and they don't expect you to force the patient to make changes to comply with a guideline that is really has set these limits, really just referencing an initiation of opioids. So Robin's been on this dose for 11 years. That's all you need to say. Next slide. The college fully understands that making rapid changes to opioid dosing is dangerous and in the vast majority of cases not necessary. So if Robin has been stable on this dose for 11 years, you really do not even need to broach the idea of tapering right away. You can take some time to get to know Robin and make it clear that you're going to at some point be talking about how effective the opioid therapy is and whether there are alternatives to it. If you are going to start to talk about tapering, you want to be really clear that you're not dealing, or as clear as you can be, that you're not dealing with an opioid use disorder. So we know that opioid agonist therapy is first-line therapy for an opioid use disorder, and tapering can be really dangerous if you're not doing that in a safe context for somebody who has an opioid use disorder. So there's a scale there, the POMI that I've referenced there, and there's a link at the end to where you can find the tool and a bit more information. That is a validated tool for patients who are taking prescribed opioids to look at whether there is, it's a screening tool to look at whether there's a potential for opioid use disorder and whether you need to look into that in more detail. So, we don't have a little electrode that we can put in the brain and say, is this opioid use disorder or not? So this is kind of the best we can do, is our history and observing the patient and having a good conversation with them to make sure that that's not what's going on. And you want to get a sense of Robin's stage of change around opioids before you ever start talking about tapering. So next slide. Most of you will be probably pretty familiar with the stages of change, but just by way of review, this is kind of the cycle that the Prochaska and DiClemente's trans-theoretical model of change that we reference repeatedly. And people are at different stages with regard to different things at different times. And even though the arrows are going in one direction, people absolutely very frequently go the opposite direction. So you need to take a little bit of time to figure out where Robin is at on this scale. Next slide. So one of the ways that we do that, very simple tool that I use is the readiness ruler. So I have a little printout of a ruler of this exact slide that says how important is it to you to make a change in your opioid plan, from it absolutely is not important to it is absolutely the most important thing to me right now, 0 to 10. And then the bonus question, if the answer is not 0, how confident are you that you can make a change now? So if the answer is 0 to the first question, I'm not moving on to the second question. If the answer is 0, this patient is pre-contemplative. Okay, so next slide. So pre-contemplation, absolutely change is not on the radar. So next slide. This patient, if Robin is pre-contemplative, Robin is clinging to the cliff face by 2 fingers, and opioids are the only thing Robin is hanging on to. I am not going to start prying Robin's fingers off of the single handhold that they feel that they have. It is counterproductive to push for somebody who is pre-contemplative. The more you push, the more you insist, the more you bring it up, the more they push back. And all that does is rehearse in your brain all of the reasons why you should not change. So it actually makes it less likely that Robin will ever change if Robin is pre-contemplative and you're pushing. Next slide. So if Robin chooses anything other than 0 on the readiness ruler, then Robin is contemplative, at least. And I think that's a really important point. We tend to assume that anybody who has not changed when I want them to change must be pre-contemplative. But actually, most patients that I talk to are actually in that contemplative phase. They've thought about it. There's some part of their brain that doesn't love this regimen, that thinks there might be another way, but it's really scary to think about making changes. So the tool that we're using for somebody who's in that contemplative stage of change is motivational interviewing. Next slide. I'm not going to go into a whole bunch of detail on motivational interviewing because that would be a session that Sasha should be leading, and B, like a 3-hour workshop. But I have the book on the right there. It's really good. It's really small. It's really readable, and you can like pull it out and read a couple of paragraphs at a time. Really excellent book on how to do motivational interviewing in healthcare. But if you go to the next slide, the very highly simplistic Coles Notes is when somebody's in that contemplative stage of change, there's part of their brain that wants to take the change road and part of their brain that wants to take the stay the same road. And we are trying to increase their confidence that it is safe to take the change road and increase their level of motivation to try out the change road. So what I'm trying to do with a patient who's contemplative is just start to get them talking about change, which makes it seem safer, which makes it seem more approachable, which makes it more likely that they might consider trying it out. So with the readiness ruler, if they give it a 2, I might ask, why not 0? You could have said 0, but you said 2. So why 2? And whatever that is them talking about why they might at some point in the future change. Another question I like to drop in is, what do you love about the hydromorphone? And get Robin talking about the things that keep Robin taking the hydromorphone, because that's really important for us to know if we're trying to frame an approach to motivational interviewing. Also, Robin might actually, the reason why I phrase it this way is actually often someone like Robin will say, well, love is not exactly the right word. And then they might talk about things they actually don't love. But then my other question is, if you could wave a magic wand and change anything at all about the hydromorphone, what would it be? Which takes it out of when you ask somebody to sort of make a pro-con list or something, it feels a little threatening, like I'm trying to get you to move toward change. This is just magical thinking. This is just dreaming. If you could wave a magic wand and change anything about it, what would it be? And then you can start to surface some of the things that Robin actually doesn't like about the hydromorphone. The other thing that can increase people's confidence taking the change road is to get them talking about other changes that they have made. So if you know that Robin quit smoking, well, tell me what that was like. What was that process like for you? And get them talking about it, which reminds them that they actually can change things when they want to. And then another, you have to tailor this. Um, sometimes this isn't the right question, but what I find very frequently is if somebody gives it a 2 rather than a 0 on the readiness ruler, and I ask them why, they say something along the lines of, well, I don't want to still be on this 5 years from now. So then my question might be, how come? What worries you? What do you think about when you think about being on the hydromorphone 5 years from now? And then again, just easing them into having some conversations that are change talk instead of stay the same talk. So mini course in motivational interviewing. Highly simplistic and overly generalized. Next slide. So
Right. Just
yeah,
want to give you a little bit of some time management wise. We have about 3 to 5 minutes kind of left for you to wrap up there, if you
yep.
don't mind.
Thanks, Abby. I'm good. Um, so when somebody's in the preparation stage, this is actually really easy. Tapering is really straightforward. The meat of this is the motivational interviewing that needs to happen when somebody's in that contemplation stage. Once somebody is saying to you things like, what would it look like if we were going to taper? Then it basically does itself. So if you go to the next slide, there's kind of a recipe, right? You talk about document the reasons for tapering. You talk about a flare up plan. You figure out what days are we going to taper and when and what's that going to look like. You just stick to the recipe. Basically, when somebody's ready to move, they're ready to move. If you go to the next slide, the best evidence that we have around opioid tapering, and there's not a ton of it, but the best evidence that we have is that leaving it patient directed is where you're going to be most successful. So if the patient says, I would like to drop by 1 milligram 2 weeks from now, then that's what you do. And you let them decide, and chances are you're going to get where you want to get to. Next slide. So I've put some resources in here, and I just want to kind of guide you through what those are. That first one is the POMI, the tool that I talked about. Specialist link, for those of you who are in Calgary zone, you'll probably be pretty familiar with. So the thing that I want to steer you toward is the pain pathways. So those are available to anybody in the province to download and have a look at other ways of managing pain besides opioids. There's also the peer pain guidelines, which are similar. There is a phone consultation available through Specialist Link if you're in Calgary zone, but they are in the process of scaling that up provincially. So there will be phone advice that you can use. I'm sure that as we go through our case discussion today, there will be resources that are more specific to South Zone that people will bring up. Oh, why did my resources go away? There it is. So there are some tools for tapering that are up there. And then also we've done lots of sessions, primarily sponsored through ACFP, around opioid tapering. So you'll find previous talks and some resources that are listed on the ACFP site there. So you'll be able to access those. And all of these will be up on the attendee hub that you can grab later. So next slide. So questions?
Thank you, Dr. Montgomery, for sharing that quick, rapid set of pearls for supporting that patient through some potential change, that's for sure. So I'd just like to welcome everybody to go ahead. You can ask some questions in the chat. Really, we'd encourage you to unmute because we'd like to hear your voice and get connected. You could raise a hand or just go ahead and unmute would be great if you have questions. Okay. Well, I might go ahead and ask a quick question myself, if you're okay with that.
Yeah.
Um, so you talked about the motivational interviewing course, which in the Palliser Primary Care Network, we primarily support family physicians with a health professional who we try to make sure that we have some skill built in that motivational interviewing. Sometimes it's chronic pain, could be many other chronic conditions we're dealing with. Is there a specific course? Because we know reading and then putting it into practice is a whole nother level of skill building. Is there a motivational course that you suggest that would really help build this skill? And maybe if you don't have a suggestion, Sasha might have a suggestion too there.
Yeah, that's a good question. We have talked about doing a motivational interviewing course and putting it up on Specialist Link. We have a CBT for pain course that's up on Specialist Link that people can have a look at, but we haven't done one specifically to motivational interviewing. Although I will say the prescribing and deprescribing course that I've linked there in the resources has lots more information on motivational interviewing. But Sasha, do you know of anything that's specific?
I am trying hard to Google as fast as I can right now because I don't know anything off the top of my head that is specific to chronic pain or that is specific to Alberta. But there are certainly lots of courses out there, asynchronous
Mhm.
courses, that you can search for. Again, I can't vet anything off the top of my head. Um, but I could do that in the background, and put that in the resource list, after today, if that would be helpful.
Sure, thanks. That'd be
Yeah.
great. I imagine Drake probably could share a bit about Alberta Health Services. It used to be called patient-centered care. It's a similar motivational course there too, but just to kind of keep us moving, does anybody else have questions they'd like to ask? A few familiar faces. Okay, I have another one if you don't mind. I'm going to hog the time here. You talked about the CPSA desire isn't to want to have these patients orphaned when you do get them on opioids, right? And I know there's always concern around documentation and expectation of tapering people. So when you're using these types of readiness tools, are you, when you're documenting these appointments with them, are you using the stages of change even within your documentation, or is there a recommendation around how you're assessing that, ability to try even starting tapering?
Yeah, absolutely. Like when I meet a patient, part of my assessment is stage of change. And so, yeah, my chart note is going to say, we discussed this. The patient is, I use the readiness ruler, the patient is pre-contemplating.
Okay.
And then typically my approach with a patient who is pre-contemplative would be to say, that's okay. We'll work on some other things. And if it's okay with you, every few months, I'm going to circle back and see whether, where you're at on this scale. And there's not going to be more pressure than that. It's just, expect that, maybe 3 or 4 months from now or 6 months from now or whatever seems appropriate, I'm going to circle back and we're going to do this again. Similarly, if you're working with a patient who's contemplative, I'm going to say that, today what we were doing in today's visit was motivational interviewing, and just documenting that, it's on my radar that I'm thinking about the safety of this opioid dose. And here's how I'm moving forward. So here's why we're not making a change to the opioid dose today.
Thanks for that, Dr. Montgomery. Looks like we do have a few comments in the chat here. One, Drake was sharing around health change methodology that's specific for chronic conditions, but could help with supporting change talk. Also, patients can be referred to addictions counselors through Recovery Alberta who are trained in this. And then lastly, if tapering opioids, methadone, are we allowed to go up to the next higher dose at all or not? To advise for patient wanting to go back up.
Yeah, so that's the rules around opioid prescribing. Methadone in particular are different between pain and addictions. So when it comes to prescribing methadone for pain, and this is the case in most provinces, we actually just did a sort of a survey nationally of comparing provincial guidelines. Um, you can. So if you are tapering, and you decide, oh, that was too much, can you go back up to the last step? Yes, you can. I would say if you're working with methadone and you're not that's not an area of comfort for you, you absolutely would be able to find somebody to sort of mentor you through that who's a little bit more comfortable with methadone. So, you can do that via phone consults. You can do that through e-advice on NetCare, your local community, and who can kind of give you some tips. Just because, you don't need to be, if methadone is not a comfort zone for you, you don't need to be doing that by yourself. Allison probably has some thoughts there too.
Yeah, I think we have time for a couple more comments or questions there, Allison, if you'd like.
Yeah, sure. So I was just wondering about opioid-induced hyperalgesia kind of phenomenon. So that's something I will sometimes discuss with patients who are more contemplative with tapering. And certainly it's not something that we can specifically diagnose on a physical exam. Usually I'm looking at someone who's been on opioids for many years, they're escalating the doses, not getting any further benefit, or their pain is actually worsening over time. And I kind of say like, hey, like, isn't this interesting? And kind of bring up some curiosity around that. Like, you've been increasing the dose, yet you're in the same position, or maybe even set back further than you were previously. But yeah, did you have any kind of pearls or insights in terms of what providers can do if they want to bring up concerns around hyperalgesia with their patients?
Oh, absolutely. For me, that's part of when I'm taking a history and I'm talking about like, how has your back pain behaved over the years? And you can sometimes sort of draw those connections and say like, oh, here's where you made an opioid increase, and here's where your dose increased again, and here's where your dose increased again, and here's where your back pain became also leg pain, and then also neck pain, and then also headache. And you can actually start to map it out, literally draw it out for people so that they can see adverse effects, or including hyperalgesia, happening as they're staying on an opioid for longer or increasing the dose, for sure. Yeah, that's one of them.
Well, thanks so much, Dr. Montgomery, for sharing your knowledge and expertise. I know that was a quick rapid fire, and we probably could keep you on for another hour, keep asking you questions and sharing pearls with us.